Vicky, is alternative reimbursement, so Lance postulates, Lance is still around. If there's any points, please raise your hand. I'd like to include, the only reason our panel is this big is that we can't fit everybody down here. So I'm happy to bring people in if you've got points that you'd like to add. Vicky, is alternative reimbursement the same as value-based care?
That's an interesting question. I think, well, alternative reimbursement models are a way of incentivizing value-based care. So I'd put it like that. I mean, they're alternative in the South African sense because they're not fee-for-service. I think that's, I mean, the alternative reimbursement mechanisms is quite a general term. It doesn't really specify. It could be something more outcomes-based. It could be a DRG. It could be, a global fee. So it's a way of it's a way of achieving. It's a means to an end of value-based care.
From your reading of the NHI as it currently stands, is this a document that incorporates concepts of value-based care or not?
So I think NHI presents a huge opportunity for a more value-based payment model in the South African system, because the idea of NHI fundamentally is to buy healthcare from both public and private providers. And they can't do that using the current systems, the existing payment mechanisms in both the public and private, because in the public sector, hospitals are currently reimbursed on a sort of global budget type approach, right, where they're given, an amount of money for the year and, told to be a hospital essentially. And the problem with that in the context of NHI is that the money doesn't follow the patient. So if the patient can choose or is going to a public or a private provider, the resources need to follow where the patient is accessing care. And with a global budget model for the public sector, that doesn't happen because the hospital is getting their money regardless of whether 2 patients, 4 patients, or 200 patients go to that hospital. On the private sector side, it would be a disaster for NHI and I don't think there's any indication that they will, but there would be a disaster for NHI to reimburse their private sector partners on a fee-for-service model. So in the private sector, the reimbursement model needs to change, right? So in terms, NHI requires a radical change in the way that we pay for healthcare in South Africa. And therefore, it presents a huge opportunity to do that in a way that is more value-based than what we do at the moment. And I would say, coming from, as you may be able to tell from the accent, coming from the UK and the NHS system, starting as you are from scratch, essentially, you have an opportunity to really learn from other systems and start with something which is more value-based in a way that, in the UK, for example, they're struggling to move away from a status quo into more value-based payments. Whereas here, because it's a blank sheet of paper, you could start with something really value-based. So I actually think that NHI could potentially be really positive for...
So my reading of it is quite, the first point the minister makes is about outcomes, which is and then goes on to talk about the cost, outcomes first. Jasper, so this issue of innovation, driving up costs without commensurate value. So for instance, issues like the fact that there's more CT scanners in Johannesburg than in the whole of the UK. And that companies like yourself, and often these are based on business, not you, use the customer, the radiologist, and the practice wants a CT scanner or MRI scanner or the latest positron emission, How do you bring these into a kind of value-based arrangement in a way that works for everybody, that works for your, or do you see this as a threat, perhaps?
Well, I think there are still doctors, physicians, hospitals that do want to turn out volume. And they just want a fee per service, so they want to do a scan and get paid. But if you put it back in the context of a national health insurance, I think without a value-based approach, you will not get anywhere because we already know that the system is constrained. We already know the costs are too high, so I think it needs to happen. And what we notice, not only with talking to the public sector, but also to private, is that people understand that they're at a turning point. So this morning, to me, was a little bit still defensive. It cannot happen because, but yeah. I remember 5-6 years ago, people were talking about Uber. They cannot get a taxi. They cannot Hey, they're here. So I think, like it or not, as an industry, we also need to embrace that the change is going to come. Do we know what that change is? No. I think we can look a little bit ahead, and we can make that as a bit of a stepping stone and use that stepping stone to make a next move. And I think what we sometimes do is make this into a very big, complex scheme, but I can give examples in South Africa where I think value-based care is being developed. There is a startup, EM Guidance. It's a very simple, it's an application, and it allows doctors to actually look for medicine and what to prescribe. So what does this actually do? It gives you a protocol, so you don't have to think, was it now for 2 weeks or was it for 4 weeks? No. You see the best practice. It also gives you the generic versus a branded one, where you can say, hey, maybe the generic is better. So I think we need to look at the total scheme, and I think the NHI is going to come. What shape or form, I don't know. But I think we have these stepping stones that we as private need to embrace. And that can be helping a startup when they do an application like this. It can be talking to a private company, a private sector, saying, can we make data available? Because if we have the data, then actually we know how many scans are done and how many might not really be needed. So yes, there are still excesses. And I think there are earning models, and we all know what good physicians make. There are earning models that people will not want to let go of. But I don't think, and again, I'm a foreigner, so I'm a guest in this beautiful country, so I cannot understand all the politics, but I think most people realize that that cannot continue anymore. So you can resist, but I think it's going to come, and I think our job, our responsibility is we want to improve access to care, and we need to work with all. And yes, it's going to feel a little bit uneasy, and there will be a little bit of scuffling and fighting, but I think there is going to be an NHI, and I think it's needed. Yeah. So we will play our part there as well.
Shrey, is this something, do you have specific, is this something that is front of mind for you, as an industry perhaps, and yourself as Life Healthcare? How do you...
As an industry, not yet. And if you're saying industry, I'm assuming you're talking about the hospital provision.
Yep.
I'd love it to be. I think we don't necessarily need legislative change for us to agree a set of quality measures that all of us should publish. We don't need that. That we could agree as a hospital body. You know, HASA could champion that. We, if you ask about Life, we publish at a hospital level the set of clinical metrics that we think should be shared. We're trying to benchmark it locally. You can't compare because we all measure different things. We try to benchmark internationally. There isn't a quality standard globally. Different countries have different measures, but that should be a norm for every major hospital group to go, here's a standard set of output-based quality outcomes, infection rates, etc. Part of the challenge, if we step away from quality, and I think, again, pausing on NHI because we've all parked access. I mean, there's 60 million people we should talk about, right? It's not just about the 8 to 10.
Yep.
That's a more fundamental issue than quality and cost. But if you come back to quality and separate that out from value-based, where you're overlaying this cost discussion, part of that is saying what's driving that. At the moment, what's driving that is personal organizations' intention to say it's the right thing to do. The system's not, like I said, designed for it.
That's a good, I mean, I use Life, for instance, to teach my MBA students about measurement, because you can go onto their website and see what the infection rate is at any hospital. Other hospitals also do it, but I think your one is a lot more easier to navigate and that kind. Do people ever do that? Have you ever, how do you choose a hospital? If somebody can, have you looked on their website?
But
Shrey, do customers, are customers interested in this?
No,
Yeah,
no.
okay.
And let me be clear.
Yeah,
People,
let's just
people,
hear. Have you looked, before
No.
being admitted to a hospital, have you been onto their website? And I can tell you that you can go onto Life Healthcare's website and look what the infection rate is.
By hospital.
By hospital for surgery. Has anybody done that? Just one. 1 out of 140.
Thank you.
Yeah, okay.
I'll come back to it, and that's the difference between, I spoke about quality and outcomes. When we talk about value-based, that's the delta, right? We can publish what we control. So sepsis. The system, when you take a patient and outcomes, there's the role of the doctor, there's the role of the nurse, there's the infection rates in the hospital, there's the what's the rules that allow clinical care to be practiced or not. All of us as a collective shaped outcome-based, right? And therein lies the challenge. To your question of how do people pick, it's not a South African thing globally. They pick geography and they pick their doctor. Almost globally, you don't find a brand that people pick unless you truly differentiate it on a topic like cardiology or oncology. Then you go, MD Anderson, I'm flying.
Yeah.
But that's the 2% of the world, right?
Yeah.